Hello, welcome to our discussion of clinical prospects and multiple sclerosis. My name is Mandy Jackson, and I'm the managing editor of U.S. Commercial News for Scrip and the Pink Sheet, and I'll moderate our discussion today. Multiple sclerosis can be difficult to diagnose, and the patients have benefited from new disease-modifying therapies, though many unmet needs still remain. We will hear from our speakers today about gaps in diagnosis and treatment, as well as promising science and technology that is emerging to address patients' needs. With us today are Dr. Tanuja Chitnis, who is professor at Harvard Medical School, director of the Partners Pediatric MS Center at Massachusetts General Hospital for Children. She also sees adult patients with MS at Brigham and Women's Hospital and serves on the board of directors of the Americas Committee for Treatment and Research in Multiple Sclerosis, or ACTRIMS, which recently held its annual joint meeting with its European counterpart, ECTRIMS. Dr. Mark Freedman, a professor of medicine and neurology at the University of Ottawa, director of the Multiple Sclerosis Research Unit at Ottawa Hospital General Campus, and senior scientist at the Ottawa Hospital Research Institute. He is president-elect of ACTRIMS. Dr. Ari Green, who is the distinguished professor of neurology and ophthalmology, chief of the Division of Neuroimmunology and Glial Biology in the Department of Neurology, medical director of the University of California at San Francisco Multiple Sclerosis and Neuroinflammation Center, and a translational scientist focused on the development of regenerative and restorative therapies for people with MS and related disorders. His team led the only successful remyelinating trial in MS to date. And Cyndi Zagieboylo, president and CEO of the National Multiple Sclerosis Society in the US. So to kick things off, let's talk about how difficult is it to diagnose MS and what is changing in this area to more rapidly and precisely diagnose patients? What else would be immediately helpful in this area? Cyndi, can we start with you?
Sure, thank you. It's great to be here. And I'll just say that fast diagnosis is critical to minimize MS and the disease that the symptoms that can occur. So from my perspective, I would say to start with heightened awareness that diagnosis and treatment early in this disease is critically important. People having access to an MS specialist is so important, and linkages with general neurologists will help us speed diagnosis. Another thing I'd like to mention around this is that we need to dispel myths about who gets MS. Awareness that Black people get MS at a similar prevalence rate as Caucasians, although the presentation may be different, we need to heighten that awareness because early diagnosis is just so very critical.
Dr. Chitnis, what progress are you seeing in the area of diagnosis?
I think in general, diagnostic criteria have certainly improved in the past 10 years, and maybe 10 or 15 years ago, initially MS was diagnosed just by clinical symptoms. Then MRI was added in. Then CSF profiles were re-added into this. And now we're starting to see some evidence that blood biomarkers might be helpful in this diagnostic phase. But there's still a lot of work to be done in that. We don't have one blood biomarker that distinguishes MS from other entities. There are also advances in antibody testing for other diseases that commonly mimic MS. And so given that sort of ability to look at a set of both clinical and blood as well as MRI features, diagnosis has improved. But as you can sort of hear from what I'm saying, it requires a specialist to put all of this information together. And so having a general neurologist or even a family practitioner start to diagnose MS can be challenging. And this is where there still is a delay in diagnosis. So I echo what Cyndi has said, that early diagnosis is critical for initiation of early treatment, which we know has benefits long term. And then I'll also add that we are seeing a lot of patients who have what's called radiologically isolated syndrome. They have incidentally presented with an MRI that shows MS-like lesions and brought to a neurologist's attention. They've not had clinical symptoms yet. And this shows us that MS very likely starts years before the initial full clinical attack. And probably if we are able to identify those people and treat them appropriately early on, and again, we have a better chance of mitigating or reducing disability in the long term.
Dr. Freedman, do you have anything to add here?
Well, I completely agree with everything Tanuja mentioned. Having served on the last McDonald committee, I can tell you that our biggest concern was not so much our ability to diagnose, but all the misdiagnosis. And we really focused on accuracy of diagnosis. The last thing you want to do is put that label on someone when it doesn't belong. And we were willing to sacrifice some degree of sensitivity so that the criteria may not fully diagnose everyone, but specificity had to be as high as possible so that when you do make the diagnosis, you're pretty darn sure that it is MS. And there's just too much of a, I will say, knee-jerk, sorry, I had to say it's neurology, a reaction for many people who just simply order MRIs for the wrong reasons. Then you get these images that are with a long list of differential diagnoses often presented by the radiologist to make sure that they've covered everything. That's even the remote possibilities. And someone latches on to the possibility that this is MS, so that now suddenly a patient who probably doesn't have the disease, has symptoms that wouldn't necessarily add up to MS, gets a diagnosis by MRI, and the next thing you know is they're placed on a treatment that could cause them some harm. So it's really important that we don't rely on laboratory measures alone, that this is very much a clinical diagnosis, that a patient has to have symptoms and signs that are consistent with central nervous system demyelination. And then we use our tools, our hands, our examination, our experience, the MRI, the biomarkers, anything, you know, the other tests, including spinal fluid, to either reassure us that we're not dealing with another entity that could mimic MS, or show us all the things that we would expect to see should a patient have MS, but not rely on those laboratory markers to make the diagnosis.
Dr. Green, did you have anything to add here as well?
Yeah, I think my colleagues and Cyndi have beautifully summarized, where things stand. I would only add that, 150 years ago when MS was first described, and in probably the first nearly 100 years of the disease, the diagnosis was almost strictly pathological for the confirmation of the disease. I mean, obviously there was a clinical sense of who had MS, but really knowing for sure was dependent on pathology. And the refinement of the clinical criteria really starting in the 1950s and 60s and on to the 80s and 90s and today has really helped us to do exactly what Mark was touching on, which is identify who has MS and who we can confirm has MS, and yet at the same time ensure exactly what Cyndi touched on, which is treat people as early as possible, which the evidence is overwhelming now that that's important for prevention of brain injury.
Well, how has treatment of MS changed as a new disease-modifying drugs have become available, and what urgent needs still are unmet from physician and patient perspectives? There's fatigue, I know, is a big concern, as well as stopping disease progression, but each patient experiences the disease differently. Dr. Chitnis, can you start?
Yeah, so MS treatments have certainly just exploded in the past 20 years since I started to practice in the field, when there was 1 or 2 treatments, and now we have close to 20. And it's wonderful as an MS clinician to be able to choose between different treatments with different both efficacy as well as side effect profiles, and find the right treatment that actually fits the patient's disease profile. I think with that, some additional matching is needed, and that's where the concept of precision medicine comes in, that I know we're going to talk about later in more depth. But finding the right treatment for the right patient at the right time, I think that was one of Mark's papers, is really something that we as MS clinicians are hopefully getting better at. I think the gaps in terms of MS treatment still remain. We would like to understand who benefits from high efficacy early treatment, and we have a sense that that type of treatment, if it is safe, does eventually probably give us better long-term outcomes in terms of disability and quality of life. But those are several studies that are ongoing to really define and prove that point. I think around the missing gaps, certainly treatments for progressive MS, or that's a challenging concept, and there's probably many mechanisms that are at play in progressive MS. but essentially slowing disability accrual that's unrelated to relapses and eventually improving neurological function is important. And finally, improving quality of life for patients at all stages and levels of disease is very important. And fatigue is certainly a major symptom that patients continue to experience constantly. I will also say that psychosocial issues and depression, anxiety are also quite prevalent, and understanding how to manage those within an MS population is critical.
Dr. Green, you were just nodding your head, so I'll ask you to speak next.
Yeah, I think Dr. Chitnis has summarized that really well. I guess what I would add is, there's one feature of having lots of different choice is the potential for paralyzed choice making. So the capacity to differentiate and distinguish who should be on which therapy is a crucial area of development. The other thing is, we've made this huge inroad in terms of therapy. It used to be that 50% of our patients at 15 to 20 years have significant or major disability, or were making a transition into a relentless, disabling, progressive course of their disease. And now we're probably pushing that out based on data from a bunch of different sites, including our own and Dr. Chitnis's in Boston, which it's clear that we're pushing things out by a decade or two in terms of when people enter that progressive disabling stage. But they still, despite our most potent therapies, still patients have both progression in the early phase of the disease and long-term progressive disability at, or major disability milestones at 20, 30 years of having the disease. And so that leaves this major unmet need of needing to have restorative and regenerative therapies. And I think that's to me, that's the next huge hurdle for us to overcome. We're making progress, but it's really where I think a huge amount of resources needs to be dedicated.
Well, and certainly these are pretty young patients relatively with this kind of a disease. So there's certainly a need to push progression out as far as possible. Dr. Freedman, can you talk a little bit about sort of unmet needs in terms of treatment?
Well, I'd like to say that I have probably a little more gray hair than my two colleagues here. And I entered the treatment arena, or at least the MS arena, at a time when there were no treatments. And then we had the era of the injectables, a huge breakthrough. We go after our young scientists. ACTRIMS has really been focusing on our young researchers, trying to get enough people out there with that kind of knowledge that we could apply it properly and get these patients the kind of management that they need. So yes, we have very effective therapies, but we want to know how to implement them early, and we want them in the hands of people who know what they're doing, so that our patients get the best chance at curbing their disease early and preventing that progression.
Well, Cyndi, outside of the clinic, for the patients in their daily lives, what are you seeing as the most urgent need among the community of patients?
Well, it's consistent with what Mark just offered. We need, first of all, more MS specialists would be helpful. People who can take care of people. There just aren't enough. At least in the United States, there are just not enough. And we need greater consensus on standards of MS care. So if we could describe what they are, and we don't know this yet, there's too many variables, but if we could describe what the standard of MS care is, we could more easily instruct, train, provide distance learning, connect with community neurologists so that they can administer that complex care that is complex. One of the tragedies that we have, on the one hand, we have this so many options, like Tanuja described. We have so many options now. That's wonderful. On the other hand, there is enormous stress that is caused when people feel they're given an overwhelming number of options, and they're asked to figure out and participate in their own care at a level that they're not prepared to do. It puts the physicians in a very difficult position. It puts patients in a really hard place that can be incredibly overwhelming, and can, I think Mark just described this, it can paralyze people. It can just paralyze people from moving forward. So that is something we need to figure out how to overcome. Simplifying the diagnosis, ensuring immediate treatment, and making sure that that treatment is aligned and the most effective for that person at that time. There's still a lot of things to figure out.
Mandy, if I could just extend for a second that, because I think one comment that's super important there too is as Cyndi was touching on, more need for people with specialist training. That's even more pronounced, I think, for our international settings and outside of the US and Europe, where the disease is probably under-recognized, and due to the benefits of globalization and industrialization. I mean, the disease is really a disease of the industrialized world, and as across the world people industrialize, we see way more autoimmunity developing, and we see way more of these diseases like MS, and we just need the specialists and the training for people to be able to identify it so they can get appropriate treatment.
Well, how can patients reinforce the urgency of addressing some of these really crucial needs, and whether it's from the diagnostic or the therapeutic perspective, or other kinds of treatments to get at these disabling weakness and fatigue and things that are urgent needs now? How can patients really lend a hand to help develop better treatment all around? Cyndi, can you?
Yeah, I'll start with that. That's great. In general, and not just in MS, but in general, people are finding their voices in engaging in their own medical care. And this is critically important. The doctor-patient relationship is becoming more of an equal partnership and with greater transparency. And we understand that knowledge and awareness of what's going on is powerful, and that people can contribute to their own solutions. When we have a group of people together and we put a problem in the middle of the table, and the problem is presented by a person who has MS, I have this symptom, I have this concern, and the experts come around, we can solve it more quickly. So just the convening, the describing what your life is like, what you'd like to achieve in your life, expressing symptoms, being able to talk about those, and engaging others in helping to solve, that's a big part of this, how we're going to get answers.
Dr. Green, from your perspective, how can the patients lend a hand and help on the scientific and treatment side?
Well, I think it's definitely that at the individual level. It's the partnership with the physician. At a broader level, I think patients have to make sure that their concerns and their issues and their worries and the problems they face are getting recognized. That includes what Cyndi touched on earlier about fatigue and other symptoms that need management to improve quality of life. It also includes the recognition that, we used to focus all of our attention in terms of what we want to prevent is keeping people out of wheelchairs. And that's an important goal, or was an important goal for an era where we had no therapies, as Mark was touching on. But now that we have therapies, we really want to avoid even more moderate or even milder disabilities that may be hidden from people who it's not obvious to people who see a patient with MS necessarily to have MS, but it impairs someone's capacity to go for a hike or go for a bike ride or enjoy walking on the beach. And those kind of things, it might seem more trivial maybe to a prior generation or to people who have lived with MS, who have serious progressive disease, but the people with more moderate disability, we need to hear them, and we need to develop therapies that help address their issues. Again, that gets to that reversal of progression and that recovery and the prevention of their long-term progressive disability. That seems to me to be the crucial boundary that we need to pass.
Well, you touched on it a little bit, but are the needs very much different depending on whether you're talking about a relapsing, remitting MS patient versus progressive MS, and pediatric versus adult patients? Dr. Chitnis, maybe you can talk about this since you treat children as well as adults.
Yes, and I'll add that we are seeing a larger number of pediatric MS patients. It's partly because of the increased recognition, better diagnostic criteria. But I think we also have to wonder if this population is increasing for other reasons. Ari mentioned industrialization as a factor, and we are seeing that obesity is a risk factor for MS in general, and particularly obesity during adolescence. And I think that, combined with studies looking at diet and the microbiome and other factors, does lead one to think about this industrial pressure and leading to MS. So I am seeing a number of kids with MS, as well as many practitioners around the world, and it's really critical to recognize that this is a very highly inflammatory disease. Children have 2 or 3 times as many relapses as the typical adult patient does. Of course, it's a continuum. And this is where it's critical to treat patients with effective drugs safely and as early as possible. And that is where early pediatric trials come in, and we've participated in a number of these to help to bring new therapies to children and really adolescents with MS that are safe and effective. So I think with that being said, the early relapsing phase of MS certainly responds best to highly effective anti-inflammatory drugs. But there's still probably a role for neuroprotection, for potentially remyelination in this early phase, since every attack, every hit does damage the central nervous system to some degree. Later on, the inflammatory phase does decrease with age. I think, that's a generality and every patient is different, but that's in general. And that's where possibly the highly inflammatory or highly anti-inflammatory drugs are not as crucial. And there is a thought around de-escalation of therapy or even stopping therapy at a certain age, maybe 60 or 50, but that's still in study and to be determined. But I think there's this concept that we will pare down or change different therapies as patients age and potentially add on more neuroprotection during this aging process.
Dr. Green, did you have something to add there?
You mean in terms of the different needs of different patient populations? Yeah, right. I think Tanuja touched on it beautifully, and there are clearly different needs for pediatric patients and adult patients. But in addition, I'd say we've got to focus on something that we've touched on a little bit, which is that each patient has their own unique course of the disease and their own unique story and their own unique pattern of damage and injury. And so personalizing care and thinking about a personalized approach becomes crucial, and developing ways of deeply phenotyping each individual patient so that we know what their, where their damage and injury is, and we can focus our attention on how to address it, and developing those biomarkers for how do you measure damage and injury in different pathways. It's the multiple part of multiple sclerosis can sometimes get overlooked, and the fact that there's diffuse damage and injury. And so how do we, again, focus on the fact that it's a multifocal disease, but with patterns of damage and injury that is different in each individual, and trying to address that is crucial.
Well,
Mandy, just to build on that, if I could,
sure.
just to build on that so much, I think because MS is, we do have courses of the disease that we describe, but each person has a unique set of symptoms. So Ari talked about this a little bit earlier, that depending on what a person wants to achieve in their life, that walk on that beach, the dance with their daughter, the ability to keep working, whatever they do, and what their symptoms are, the intersection of those. So one of the challenges that many people have is that their symptoms are invisible. Somebody can run a marathon, but they can't add a column of numbers because they are experiencing cognitive fog, or, so it's a challenging disease to approach, and that's the way we have to approach it. We have to look at what does a person want to achieve in their life, what is their problem, and what is a potential solution to that, which is managing symptoms, and of course minimizing, eliminating disease progression as part of all of that. So it's a complex treatment that includes the whole person and the relationships.
Well, how have patients become involved in the development of new treatments and diagnostics? And when I say treatments, not just drugs, but other non-drug interventions like digital technologies or physical therapy and rehabilitation. How have they put their voice forward and said, these are the things that really help for us?
Well, part of it is being able to describe it, and insisting that how fast I walk in 20 feet is not who I am. It's not everything I need. And being able to talk about that and describe that and advocate for it, inspire researchers and people who want to help to solve these clear problems as they're put forward. It's not simple, but working together, bringing every perspective together to think about what it is we're trying to accomplish will accelerate progress in all areas.
And that really touches on a crucially important point, which is a lot of what we have missed in MS is what's difficult to see or measure at the bedside. And so we've ignored a lot of the different features of the disease. When I came into the disease, a heavy focus in my own clinical practice and in my own research was in the visual system. And some people would say, well, why are you focused on the visual system? People get, they end up with a cane, they end up with a wheelchair, they don't end up blind. And the reality is a lot of people have significant and profound visual impairment, but it was ignored because it was tougher to measure and even more pronounced for the cognitive deficits and something we don't even like to talk about, which is sometimes the behavioral and mental health consequences of disease. And so as we move forward with therapies, exactly what Cyndi was touching on, we've got to develop the therapeutic approaches that attend to those individual needs, recognize it is a whole brain disease, and the brain as a highly complex organ underlies so much of what makes us human and so much of what permits us to live our best life.
Dr. Freedman, how have you seen patients become involved in bringing new treatments forward?
It's very difficult to move forward in any kind of a granting process for researchers if you're not involving a patient or a group of patients sitting and looking and reviewing and understanding rationale for certain research and getting them to, I think, buy in and weigh in and say, what would the impact of this research be for you? And so they're sitting on committees, they're up front, it's very strongly suggested when you submit a grant now to either the national CIHR, which is our equivalent to, I guess, your MRC or NIH, and or the MS Society, that you have involved a patient or a group of patients who could contribute to this. So not only are they right up front now looking at the process of getting money to researchers, but they're also getting involved in clinical trials. We need them desperately to enroll, especially in the trials that we're doing today with a progressive disease. We need their buy-in for that. We need their patience, not just them, but their patients, because these trials are very tedious to do. We need their buy-in to that. We need their understanding of what a PRO is, and we need their help to develop good PROs so that we're getting at that cognitive fog that Cyndi talked about. We're getting at measures of fatigue. We're getting at some of the more nebulous symptoms of pain and how that involves them on a day-to-day basis, because we don't have good measurements objectively. So we're going to have to go to these PROs, and we need our patients' help to do those.
Yeah, I'll add to that. I think that beyond, as Mark had mentioned, beyond clinical trials, which are crucial for us and really patients to understand which drugs might be beneficial, there is a real importance to participating in studies related to the natural history of MS, understanding biomarkers, biorepositories, and both Dr. Green and I are very involved in long-term biorepository studies at our centers, and others around the world are doing the same thing. But these sort of studies will help us to understand the heterogeneity amongst MS patients, who has cognitive difficulties, who is more likely to have visual difficulties or walking difficulties, and then also developing these types of novel measures that will ultimately help in bringing new clinical trials or different clinical trial strategies to the forefront.
Well, what other kind of collaborations could be helpful in advancing the field and meeting some of these needs? Are there better opportunities to bring together stakeholders, in addition to patients and physicians and academics, regulators and biotechnology companies as well, to work together? I know a lot of that work is ongoing, but surely there is a need for more collaboration or different types of collaboration to push things forward. Maybe Cyndi, you can talk a little bit about that.
I think, convening and sharing information, data sharing is really important. We're seeing how much we're learning about COVID and MS because we have registries that we set up to be able to harmonize those registries, and we can look at we did it very, very quickly because of the urgent need. We can do this. We can increase data sharing in MS, and we are doing better, but that will accelerate progress terrifically as one of the additional pieces. That and just getting together and sharing results. So the scientific meetings are critically important, and more opportunities for people to get together in smaller groups and more often to share what they're learning is going to continue to accelerate.
We have these snapshot views when they come into the clinic, but the notion that they have a dynamic disease that fluctuates day to day, might there be an opportunity for artificial intelligence to capture some of this? And what about a company that's willing to devote the resources to develop such things? That's the kind of partnership that will advance and get us a handle on our patients in the long run that we can't possibly get from, say, 2 or 3 visits a year. So partnerships like that, obviously for innovative ways of evaluating people. And I think the rest is quite endless if you start to bring in the physicists who understand some of the disabilities and I had this wonderful interaction with this fellow who's both an engineer and a neurologist who had conceptualized ways in which to deal with some people's individual disabilities and make life easier for them. Getting them involved and partnering with them, you could just, the sky's the limit when you can start thinking about the kinds of interactions and understanding that we can gain from even a basic chemist who might have an idea about a compound that will deal with a symptom that we can't currently treat.
Dr. Green, did you have something to add here too?
Absolutely. So, and beyond information technology, I think robotics and engineering are going to be crucial for aiding our patients who have significant or profound disability. And so we've got to have partnerships and engagement with people who understand the limits of those approaches as well as the potential applications. In addition to that kind of engineering approach, we need engineers to help us with developing those new sensitive biomarkers that I think a few of us have spoken about. So in fact, I have a member of my laboratory, strictly engineer trained PhD, who's become conversant in the biology of MS so that she can develop an approach for making measurements that are extraordinarily fine and that could be used for long-term tracking. And then the last part is, I think we're really missing, we have great collaboration between the pharmaceutical companies and individual investigators and academic locations and people who see high volumes of patients, but a real in the dirt kind of engagement between biotech and benchside discoveries and clinicians in the field, like what we see in cancer, I think is missing from our field. I think there's not quite enough of it. There's not quite enough of that regular engagement and conversation. This is across neuroscience, clinical neuroscience, but it's, I think the place where it could really hit pay dirt is in MS, because we've shown success in the past. So there's the capacity to do something important, but we need that engagement with the biotech community directly with people who understand the disease and the challenges that patients are facing.
Well, in the spirit of bringing people together to talk about MS, after the recent joint ACTRIMS meeting, what were some of the themes discussed during the conference that you think could have an impact on diagnosis and treatment, Dr. Chitnis?
I think the recent ACTRIMS MS virtual meeting highlighted a couple of themes for me. I think one is the concept of precision medicine, and we've seen in cancer therapeutics and cancer in general that this is really advanced significantly. We're just starting to see that in MS, and developing biomarkers that will predict or associate with new relapses and predict progression and help us to stratify or identify the right treatments for patients are now being advanced. And there were several presentations around both blood-based biomarkers as well as MRI biomarkers that might help to do that and help physicians to really stratify and identify patients at high risk for any of these events. I think that, to me, was one of the major themes. Another really interesting area is the microbiome, and I think the effect of both the gut microbiota as well as the lumen and various cells that populate the gut is showing us that that is an important organ in MS, and we need to pay attention not only to our diets, but maybe even modifying and thinking about therapeutics that would affect the gut in particular.
Dr. Freedman, what did you take away from the conference?
Actually, it was an incredible meeting. It was one of the few conferences I actually got to most of the lectures. Because what happens when we put a whole bunch of specialists in one spot, everybody takes advantage and has meetings, and you end up missing all the talks and presentations. You have to go back and do it afterwards, but I did it in real time. I actually really enjoyed a few areas right from the kickstart, where one of my country compatriots talked about the MS prodrome. And how intriguing is that, for years before patients ever actually present, there's very good evidence that they are already afflicted by the disease before they actually come out with an episode that really says, oh, this is MS. They utilize more healthcare services. They're more depressed. I mean, the list went on. It was a wonderful lecture, but there's good evidence that this could last years before the first real opportunity for the disease to express itself. A lot of those symptoms are not things that you would attribute to MS. We've seen a study years ago from the Argentinian pediatric group. Tanuja will remember this, that before they express their first episode of MS, they've already seen a decline in their grades going back 3-4 years. So there's a cognitive issue that comes out very early. From the use of healthcare services in Canada, which you can track because we have a National Health Service, you can see them drawing on psychiatrists and coming to the hospital more with general aches and pains. This was all part of the prodrome. And what really hit home was that if you look at one of those biomarkers, one of the most promising one being serum neurofilament light. So there's evidence of this prodrome that we need to tap into. We clearly, our diagnostic criteria are missing a number of people for that crucial early diagnosis and introduction of therapy. There is a lot of talk about remyelination, repair, regeneration. There's not enough of that. We are in dire need of something that will repair, regenerate, and renew, and all these kinds of activities that are being done and researched in animals need to translate into the human trials. And we're starting to see these. Ari is one of the first people to be able to bring one of those forward.
So I see a direct link between that program and the remyelination and repair topic, because I think the fact that by the time we diagnose someone, by the time we first even have an opportunity to see them in the clinic, there's already injury, means we've got to be tackling this problem of regeneration and repair if we're going to keep people, having healthy lives that are equivalent to their peers. So that's one of the reasons that I think it's a major motivator. And that was a part of the meeting that it was really exciting to see the number of different people who are becoming engaged and focused on this topic, because we need great minds from all sides, people who've had a ton of experience to help us advance that target.
Well, it seems like there's a lot of options out there for looking at new ways to tackle the disease. How, outside of things like remyelination and pharmaceutical approaches, what sort of non-pharma approaches are out there? Things like digital technologies and sleep trackers and activity trackers and wearable devices and apps and all of those. I mean, Cyndi, maybe you can talk a little bit about how patients are embracing technology to help them in their disease.
Well, I think one of the big areas that we're focused on now is just lifestyle choices that people make. So it's not necessarily just technology. It's how do you live your everyday life? How are you eating? How are you exercising? How does that affect your symptoms that you're having? So there are a lot of technical tools that support people with that. Gina described earlier how weight can be a factor for, especially obesity during adolescence affects whether or not people get MS, but obesity in general can be a big problem for people with any chronic disease and certainly with MS. So those kinds of the technology that links people together to solve a lifestyle issue, to lose weight, to be part of a group, to get that social support, to address their depression that they might be having, to make connections. Those are really important areas for people who have MS.
Well, I did want to go back to personalized medicine a little bit and ask about how you're using that now in practice. In what ways are you trying to personalize treatment, given that personalized medicine we think of more, I think, in cancer, but I know there are companies that are trying to look at personalized approaches, and certainly each patient has individual needs. Dr. Freedman, could you talk about that a bit?
I think actually the theme of our Actors Forum last year was personalized medicine and how we're evolving. And people would think, oh, well, we're far away from it. In cancer, they have an advantage. They take the tumor out. They can see the genetic composition. They can go after that gene. They can see which patient's going to respond to which drug. Yeah, they have it a little bit easier, but all of that is starting to happen now for multiple sclerosis. We just published our treatment optimization recommendations on how to manage MS all across Canada. That just came out a couple of months ago. And it involves a number of steps. And the early steps is important is to just profile your patient. They're all unique, exactly what Cyndi was saying. They all present differently. They all bring different things to the table. And we have to look at that whole package. It's not just, let's pick this drug for that, but this is not maybe the right drug for this patient. They're not going to comply with this therapy. They're not going to follow the recommended monitoring. They're traveling too much. This is an issue with vaccinations. And so it really is looking at the entire package. We have certain markers of the way the disease present clinically, the way in which the silent disease manifests on MRI. We have a biomarker now can give us prognostic. We've shown that the higher serum neurofilament level at baseline predicts an early progression that might confer a choice of a therapy that might be a little more aggressive, but in that particular individual, it's warranting it. So it's not something I can summarize in 30 seconds, but we really are moving towards that as we gain more information about the natural history of the disease, how it presents, how it manifests in individuals, and then we tailor it down to that particular patient who's sitting in front of us. And we work together with the patient to come up with the best formula for them.
Well, we're nearing the end of our time, but I did want to give each of you an opportunity to sort of look into your crystal ball a bit and give, where do you see the field 5 or 10 years from now? What is your prediction for progress, I guess, we hopefully will make for patients? And Dr. Chitnis, I'll start with you.
I think MS has certainly advanced in the past 20 years significantly, and I'll say in another 10 years there's going to be even more advances. I see that patients will have many more treatment choices. I think we will get better at personalizing those treatment choices and assigning the right treatment or treatments at the right time, and combining these with paraclinical strategies like diet and exercise and others. And I do see also an AI approach to an algorithm approach, which would help clinicians to make these decisions. So I think large databases, really bringing in biomarkers, different algorithms will help both patients and physicians to reach the best choices.
Thanks. And Cyndi, from the patient perspective, what is your hope or expectation for 5 or 10 years from now?
Well, I am an eternal optimist. I've been in this field, as probably as long as Mark, well before, since 1985. We had nothing. People weren't diagnosed. The progress that we've made since then has been extraordinary, more than any other neurological disease. And the progress is accelerating. You can hear one of the things that was discussed, at least peripherally, and starting to say it out loud, researchers are saying it out loud, that there's a potential for a cure. And using that cure word is huge and can inspire enormous hope for the field. And we are a strong MS movement with great respect. You could hear it among the researchers and clinicians here, that the enormous respect for people who are trying to live their best lives, who have MS, for the industry, for the academic research, for all the different components that are going to contribute to solutions. And that's powerful. Together, we'll make even more progress moving forward to get to that cure eventually.
Dr. Freedman, do you want to talk?
I just wanted to say that what we're seeing evolve with the different therapies today, I think the future will tell us a little bit more about what mechanism may be at play in our patients, so we're better selecting the kind of drug that will address that mechanism. We are looking at not only medicines that curb inflammation, the damage, but we're now looking at medicines that might offer repair. I can see combining these two. I don't see any reason why you wouldn't. We know that damage is occurring even before the patient begins, so we'd want to start with a reparative together with something that will curb the inflammation. We may even consider looking at some of the drugs that we have today that work by different mechanisms and combine them safely, because we don't know maybe which mechanism may be operating, but if you hit 2 or 3 at a time, you'll have a better success than any one therapy by itself. That was the lesson that HIV taught us years ago. So I can see the field evolving a little bit more in that direction, and it speaks to this precision medicine that we're seeking for MS.
Dr. Green, do you have a final word for us?
Sure thing. Yeah, so I would just second the opinion. This is an extraordinarily exciting time in MS research. I got started in MS research in the late 80s and early 90s, and there was a lot that was needed to be done at that moment. And there's still a lot that needs to be done, but we've made huge progress. And I think the opportunity for that next generation of therapies is right around the corner. It has to be grounded in not just good, but great science. I think we've got to continue to push for great scientific breakthroughs. Again, that opportunity is there. It's going to take coordination between governmental support and patient advocacy groups and corporate and private interests to help push that all forward, along with those of us who care for patients with MS and people with MS. But it is around the corner, and I think if we keep that target in mind, I do think this will be the area that'll teach the rest of neuroscience about how to tackle these degenerative diseases that are otherwise, probably the greatest unmet medical need, not just in our area, but across all of medicine.
Well, thank you all for participating, and thank you for WuXi for hosting us today.